with Nagpur OBGY. Every month you have this session, or how is it?
Second
Twice
and
a
fourth
month.
Thursday. Second and
Second.
fourth
Twice a
Thursday.
month.
Oh, wonderful, wonderful.
And twice
Very
a month.
nice. Twice a month. Nice for all
See-
postgraduates.
See, Doctor, when a president is a thorough academician, you have to have such series here.
Absolutely.
You have-
No, but
Exactly what-
what is appreciable is CMEs are there for practitioners, but for students, no, very less CMEs are there.
Yeah, that's why when she
That
said
is
that
important.
people, you do it, I immediately jumped in. Yes, I will do it.
And to make them speak, I think is the need of the
Absolutely.
hour.
Because
Yes.
people have so many inhibitions. Simple case presentation is very questionable nowadays.
Yes, so
Like,
true.
and
We are live now. We can
We are
start
now.
the program.
Okay, yeah.
Okay.
Okay.
Over to you, Dr. Rajni.
Yeah. Good evening, all dignitaries and students. Myself, Dr. Rajni Kamble, Assistant Professor in SVNGMC OBGY Department, Yavatmal. Welcome you all for the live webinar of PG Star Series 8 of Nagpur OBGY Society in collaboration with SVNGMC Yavatmal OBGY. At the outset, I would like to congratulate NOGS President Dr. Sushma Deshmukh ma'am and Secretary Dr. Pragati ma'am for their exclusive and much needed PG Star series. And I really admire their innovative drive and thank them for giving us an opportunity to be a part of it. I would like to extend my gratitude to respected Dr. Kshama Kedar ma'am, a legendary HOD of SVN JMC Yavatmal, for involving us in this webinar. So now to start with the session, Dil Da Mamla Hai, I invite President of NOGS, Dr. Sushma Deshmukh ma'am, for a welcome address. Over to you, ma'am.
A very good evening to all, respected seniors, friends, my budding PG friends. Really a hearty welcome to all for the 8th webinar of PG Star series by Nagpur OBGY Society in association with Government Medical College, Yavatmal. So, our dil se thanks to Dr. Kshama Kedar, my friend. And
Thank
today, aaj to dil da mamla hai. And we know, दिल तो पागल है, यह दिल दर्द बीमारी लेगा और पूरी दुनिया को सताएगा, लेकिन हमारे डॉक्टर भी दिल वाले हैं और दिल वाले बीमारियां सुलझाएंगे. So we are having Dr. Pallavi Thakre, one budding gynecologist dashing dil. She ventured to present a case on ANC with heart disease. And we know, ANC patient is always on dil mange more care category. But with heart disease, it becomes a very, very high risk pregnancy category and more. So, और दिल का मामला सुलझाने के लिए बड़े लोग तो चाहिए, क्योंकि दिल दीवाना बिना सीनियर्स के बिना माने ना.
Very nice.
So we invited Dil specialist Dr. Anjali Kanere from Bhopal and Dr. Avantika Gupta from AIMS Nagpur to solve this matter. Both are very affectionate and expert Dil ke khiladi hai. Both will go to the root and tell Pallavi, Dil cheez kya hai? So welcome Dr. Avantika Gupta and Dr. Anjali Kanere. पर दिल है कि तो मानता ही नहीं, पर दिल है कि मानता ही नहीं, दिल तो है दिल. So it will risk the pregnancy again and again with different forms. So we invited दिल को समझने वाले, दिल वाले, gynec genius Dr. Anisha Gala from Hyderabad. She is going to speak on understanding heart ailments in pregnancy and their management. Welcome Dr. Anisha Gala. लेकिन हम ऑब्स्टेट्रिशियन को पल पल दिल के पास ही रहना पड़ता है. So Dr. Kshama Kedar, Dr. Manoj Chelani, दिलदार सीनियर खिलाड़ी, full of love and very affectionate. They know, दिल तो बच्चा है, तकलीफ तो देने वाला है. So how to solve its tantrums? So welcome Dr. Kshama Kedar and Dr. Manoj Chelani. I
Thank you,
also
dear.
welcome the audience, respected teachers and friends. Dr. Rajni Kamble tried to bring together all Everdil gynecs, Dil wali gynecologists. So the discussion will be Dil se Dil tak. That is doctor to patient, doctor to doctor, doctor to PG. Our conveners, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, Dr. Prachi Dikshit, always Dil dal ke organize all PG activities. Our NOGS secretary, Dr. Pragati Khadatkar, is always there, Dil ko samajhne aur samjhane ke liye. So friends, let's enjoy Dil ki baat hai. Thank you.
So examiners for today's session, Dr. Anjali Kanhere ma'am. She is MBBS MD FICOG, former fellow GSMS Mumbai, and professor and head department OBGY Bhopal, and president Bhopal OBGY Society 2021-22. She is a recipient of Dr. Jagdeshwari Mishra Best Poster Presentation Award for the 3 consecutive years in AICOGs. And another examiner is Dr. Avantika Gupta ma'am, MS DNB MRCOG UK, Associate Professor of AIMS Nagpur, 30 national and patent publications, recipient of Young Talent Award Foxy. I welcome you, ma'am. So I now request to presenter of today's session, Dr. Pallavi Thakre, to start with the case.
Thank you, ma'am. Good evening, everyone. So the today's case for discussion is heart disease in pregnancy, and myself, Dr. Pallavi. So I'll be telling the case history. My patient X, she is 22 years primigravida with history of 7.5 months of amenorrhea. She's a resident of Savangi Sangam village, Ghatanji Taluka, Yavatmal. She is Hindu by religion, belonging to lower middle class, homemaker by occupations, and educated up to 8th standard. She is a known case of rheumatic heart disease and is on penicillin prophylaxis. Patient came to OPD with the chief complaints of discomfort after moderate to heavy work since last 2 weeks and complaints of easy fatiguability since 2 weeks. The history of present complaints. Patient was comfortable doing her routine work since last 15 days, and since then she feels little tired by evening and feels some uneasiness after moderate to heavy work. There is no breathlessness or paroxysmal nocturnal dyspnea. History of present pregnancy. Patient conceived spontaneously 3 months after the marriage. Pregnancy was diagnosed at 5 weeks by urine pregnancy test at home, and then it was confirmed by ultrasonography by 3rd month. She is registered at PHC Parvaden and then got 2 visits in her first trimester, where all her antenatal investigations were done. She was screened for anemia and diabetes. Then she had visited at a private hospital for her cardiac condition, and echocardiography was done, which was told to be normal. She received folic acid tablets in her first trimester. There is no history of any excessive nausea, vomiting, fever, or burning micturition in her first trimester. There is no history of any hospital admissions for any medical or surgical illness or any medicine intake. In her second trimester, she had total 3 visits. She took regular hematamics and calcium intake from 4th month. She received 2 doses of tetanus toxoid in her 4th month of gestation, 1 month apart. Anomaly scan was done at the 5th month of gestation, which was told to be normal. She felt her quickening at 5th month of gestation, and since then she perceived normal fetal movement. Repeat DIPSI test was done at 6th month of gestation, and it was told to be normal. Her BP readings were were within normotensive range. There is no history of any fever, breathlessness, palpitation, chest pain, swelling, or lower limbs in her second trimester. In her present pregnancy, in 3rd trimester, now she is admitted at 7.5 months of amenorrhea for discomfort after moderate to heavy work and easy fatiguability since last 15 days. Blood and urine investigations are done. ECG and echocardiogram to be done. There is no history of any raised BP. There is no history of pain in abdomen or leaking PV. Vitals are being monitored. Pulse rate, blood pressure, saturation, and her chest auscultation is being done. For fetal monitoring, FHS monitoring is done and DFMC counts have been taken. Now she perceives adequate fetal movements. Obstetric history. It was a non-consanguineous marriage, and now she is married since 11 months. She is primigravida and it was a spontaneous conception. Menstrual history. At the age of 13 years, menarche was attained at the age of 13 years. Past cycles, they were regular, 3 to 4 days at the interval of 28 to 30 days. It was normal flow, and there was no history of any dysmenorrhea or passage of clots. Her last menstrual period was 4th Jan 2023, and her expected date of delivery is 11th October 2023 by Negley's rule. And so by that, her currently by date, she is 30 plus 1 weeks of gestation. Past history. Patient was diagnosed with heart disease at the age of 14 years when she presented, wait, ma'am, PPT. Okay, thank you. Past history. Patient was diagnosed with the heart disease at the age of 14 years when she presented to private hospital with a history of breathlessness on exertion for a period of 3 to 4 months prior to presentation. After that, at that time, history of rheumatic fever was elicited from her mother. That is, that she told that there was episodes of fever and joint pain in her childhood. After that, ECG and chest X-ray and echocardiogram and other investigations were done, and the diagnosis of rheumatic heart disease was made, for which patient took medication for 1 year. Since then, patient is put on penicillin prophylaxis every 3 weeks. There is no history of any surgical intervention, no history of any exacerbation of symptoms, no history of ICU admissions till now. There is no history of diabetes, hypertension, asthma, or tuberculosis. Family history. In family history, there is no history of diabetes mellitus, hypertension, asthma, tuberculosis, or any other chronic medical or surgical illness in the family members. Personal history. She consumes mixed diet, appetite is good, she sleeps adequately, bowel and bladder habits are regular. There is no history of any drug allergies, and there is no history of any addiction. So for summary from the history, we can get that she is 22 years primi gravida, 30 plus 1 week gestation, a period of gestation. It was spontaneous conception, and she is a known case of rheumatic heart disease on penicillin prophylaxis. And now she presented with complaints of discomfort after moderate to heavy work and easy fatiguability since 2 weeks, which is NYHA class 2. Ma'am, may I continue for examination?
Yes, please. Continue.
Yes, please. Yes, please.
Yes, ma'am. On general examination, patient is sitting comfortably and is well oriented, moderately built and nourished. Her height is 154 centimeter and her current weight is 62 kgs. The pre-pregnancy weight is 55 kgs, and from that the BMI comes to be 23.19. Her total weight gain in this pregnancy is 7 kgs till now. The patient is afebrile at present. Pulse is 86 beats per minute, regular, good volume, no radio-radial delay, no radiofemoral delay, or all the peripheral pulses are palpable. Her blood pressure is 120/70 mmHg taken on right arm sitting position. Her respiratory rate is 16 per minute and it is thoracoabdominal. Saturation is 98% on room air. Her jugular venous pressure, her JVP is not raised. She has mild pallor, and there is no edema, icterus, cyanosis, clubbing, or lymphadenopathy. Her orodental hygiene is well maintained. On systemic examination, on
Dr.
cardiovascular.
Pallavi,
Yes, sir.
Can you just put on full screen?
Yes, sir. Full.
Screen. Slide is shown. Yeah.
Just
Slideshow.
go to, yeah. Do it from current slide also. That will also work.
Yes, ma'am. Okay.
Great.
Thank you, ma'am. In systemic examination, cardiovascular system on examination, on inspection, the apex impulse is not seen and there are no visible pulsations. But on palpation, the apex beat is felt at 5th intercostal space, which is 1 centimeter lateral to the mid-clavicular line. It is regular. There is no thrill, there is no parasternal heave. On percussion, the dullness is felt at apex. On auscultation, the heart rate is 86 per minute regular. S1, S2 is audible, but there is loud S1, and in mitral area, mid-diastolic murmur grade 2 can be heard. There is no abnormal sounds heard in any other regions. On the respiratory examination, the air entry is bilaterally equal. There is no adventitious sounds heard. On per abdo examination, on inspection, the abdomen is uniformly distended. Linea nigra is present. Stria gravidarum is present. Umbilicus is normal. Hernial orifices are intact. On palpation, after voiding of urine and correcting dextrorotation, fundal height comes to be corresponding to 28 weeks of gestation. And her symphysiofundal height on measuring is 30 centimeter. On performing the obstetric grapes, on fundal grape, it is soft, broad, irregular, non-palatable mass, which is suggestive of breech. On left lateral grip, there is a smooth, broad leg structure suggestive of back. On right lateral grip, it is irregular knob-like structure suggestive of limbs of the baby. On first pelvic grip, there is a hard globular palatable mass suggestive of head. In second pelvic grip, the fingers were converging suggestive of non-engagement of presenting part. And liquor feels to, and on palpation, the liquor feels to be adequate. On auscultation, the fetal heart sounds were heard on left spino-umbilical line around 140 beats per minute regular. On per speculum examination, the os was closed and there was no leak. And the probable diagnosis from the history and examination is she is 22 years old, primigravida, 30 weeks and 1 day of gestation. She is a known case of rheumatic heart disease with findings suggestive of rheumatic stenosis of mitral stenosis of probably rheumatic origin. She in sinus rhythm with no evidence of infective endocarditis, not in failure with NYHE class 2. Yes.
If I could ask you, which PG year are you?
Ma'am, I'm third year.
Like just have started with your third year.
Yes,
Just
ma'am.
feeling.
So really, it was a great presentation. I guess you have covered almost everything in your history. Wonderful presentation.
Thank you so
Really
much.
very impressive.
Thank you
But
so much.
I would like to ask you why, when you are saying NYHA class 2, why are you saying not in failure in the probable
Yes, ma'am.
diagnosis?
Yes, ma'am. It is already, if it is an NYHA 2, it is
Yes.
not in failure. Yes, ma'am.
Yes. If it is NYHA class 2,
4
she is not in failure.
failure. Yes, ma'am.
Yes, but it was a wonderful presentation. Really, Madam Kshama Kedar, you really are a master teacher. Because kaan teres gaye, Madam, is type ki history sunne mein, the level of confidence is really enormous.
मेरे
You may
बच्चे बहुत
say कि-
अच्छे हैं मैम मेरे
You
बच्चे
may
बहुत
see
ही अच्छे हैं
कि अंजलि तू शुरू से ही तारीफ कर रही है, लेकिन she has really done a wonderful presentation. Very
Yes, ma'am.
nice.
Very nicely she has done it. Yeah.
Yes,
And
definitely.
she has covered it everything, I think.
Yes. So if you can just let me know, what do you mean by NYHA class 2?
Ma'am, NYHE is a grading system that is based on symptoms for function to know the functional status of heart. And for NYHE class 2, it means that the patient is having slight discomfort only on doing moderate to heavy work.
Yeah, so true. So how exactly are you going to manage this patient? Like she's at 30 weeks right now. So how exactly are you going to manage her now onwards?
Ma'am, she is 30 plus 1 week, so 30 weeks of gestation, ma'am, and she came with the complaints of discomfort. So previously she had no complaints. So she was NYHA 1, and now since she is NYHA 2, so there is increase in the grade of the functional status of the heart. So in that case, we have to admit the patient because we have to rule out the cause leading to the worsening of the heart status of the heart. So first we will admit the patient. After admitting the patient, we will do the investigations, and after doing the investigation, since heart disease is a high risk pregnancy, it should be a multidisciplinary approach, and we will also involve the cardiologist, and further anesthesiologist if required can be involved, and other specialists can be involved. And after that, after the investigations and the cardiac opinion, we will come to know about the functional status of the heart. And at 30 weeks, what we can do is can ask her to, we can then, after the investigations and the cardiac opinion, we will plan the management of the patient accordingly, ma'am. So for 30 weeks, since in heart disease, ma'am, it is seen that the preterm labor pain is more common. So we can give her a steroid coverage at present, and then ask her to rest, and then we will ask her for I will also try to restrict the salt, and then after knowing the echocardiography and the functional status of the heart, we will take the cardiac opinion, and then we will decide whether to start some cardiac medications if they are required to the patient. And at present we will plan about the further mode of the delivery and further whatever management will be required as well.
Yeah, the best part will be probably to counsel her and her family members
About
to
yes, ma'am.
bring her to the tertiary care center
Care center and
for
admit
better
her.
maternal and neonatal
Fetal outcome,
outcome.
ma'am.
Yes, right.
Ma'am.
You have rightly pointed out that it is a team approach. So not only the cardiologist, the anesthesiologist definitely needs to be aware about it, because she may land up in a cesarean section.
Preterm labor pain
So
or
they need to
C-section.
know about it. And then
Yes,
the another part which you have missed is who
Ma'am,
else
we will
needs to
also counsel the relatives and the patient regarding the morbidity associated with the heart disease, also the fetal outcome associated with the heart disease.
So you need to have pediatrician also in your
Yes.
team. What is the common neonatal complications which the patient can have?
Ma'am,
And I think even your patient may have that, because you are
yes, ma'am.
saying,
Yes, ma'am.
what is
Ma'am,
it?
premature birth, preterm birth can be there, and a preterm baby can be born. So that could be the most common neonatal complication in this case.
And one more thing.
Ma'am, a fetal growth
Heart-
restriction can also be
Yes.
there,
So
because in heart
I
disease,
guess even your patient can have that. She's a
Have
30
this,
weeker. Your abdominal examination shows her as 28 weeker. So
yes,
maybe there could be a start, because
of
they
it,
present in third trimester. So you need to have the pediatrician also on board.
yes.
Anyone else for the questions, please?
Dr. Pallavi, can you show the examination slide?
Yes, ma'am. This one, ma'am.
Next slide.
Yes, ma'am.
Parasternal heave.
Yes, ma'am.
What is parasternal heave?
Parasternal heave, ma'am. Usually in patients of mitral stenosis, what happens is there is stenosis leading to the left atrial enlargement and further leading to increase in the pulmonary artery pressure, leading to pulmonary artery hypertension. And in parasternal heave, what we do is we palpate with the help of ulnar border of the hand. We palpate parasternally if there is any pulsation felt. And if they are felt, we can say that it is suggestive of pulmonary pulsations, and patient can be having pulmonary artery hypertension. So it is lifting of the hand due to the pulsations.
Due to pulmonary pulsation.
Yes, ma'am. Pulmonary artery.
Pulmonary artery. Pulmonary hypertension will lead to right ventricular hypertrophy.
Hypertrophy, yes, ma'am.
What we are checking.
So what is involved? Like, what is the cause of the heave?
Cause of the heave, ma'am, as ma'am said, right ventricle will also enlarge, and due to right ventricular enlargement, there could be uplifting with every bit. There could be lifting of heart, leading to lifting of the sternum, and heave can be felt.
And what about murmur? You have not described it well. You have written just mid diastolic and grading. How do we
Ma'am,
describe?
Ma'am, in case of mitral stenosis, what we get is mid-diastolic murmur. Then there is
No. How you describe pulse? There are certain features
Criteria.
should be there. So
Yes.
for murmur, how do you describe?
Ma'am, we will describe the area of murmur. Then we describe about the grade of murmur. Then also with inspiration and expiration, if the murmur is decreasing or increasing, that we describe. And
Yes. Radiation.
yes, ma'am. Variation with the inspiration, expiration.
And radiation, radiating
And
to
radiation.
axilla
Or yes, ma'am.
or somewhere. Yes.
Yes,
So you should write that completely. And can you tell on examination finding whether it is severe MS or mild or moderate? What are the supporting evidence which will tell you the severity?
Ma'am, grade of murmur will also tell us about the severity of murmur by grading that. If it is grade 1, it can be a normal physiological pregnancy, can also have a grade 1 murmur, that is soft systolic murmur due to the hyperdynamic circulation, due to increased cardiac output. And grade 2 murmur is when the murmur is can be easily audible, easily audible. And
No, that
the
is
grade,
grading of murmur for your patient. Can you tell on examination finding whether she's having severe MS or moderate or mild MS?
okay, ma'am. Ma'am, my patient is not having any symptoms related to dyspnea or severe symptoms like paroxysmal nocturnal dyspnea. So we can say that it is not a severe grade. It could be mild. And if when these severe symptoms are only when the area of mitral valve is less than 2.5 centimeter. Whenever
So
the area,
what is the normal mitral valve area?
my normal mitral valve area is 4 to 6 centimeter, and whenever it is less than 2.5 centimeter, the symptoms they exacerbate, and all the severe symptoms like PND, and then PND can arise, and patient can have progressive orthopnea and dyspnea.
So my next question is, how exactly can you differentiate whether this is breathlessness or dyspnea in a normal patient, except history, or this is really because of the cardiac lesion? That is what even madam was trying to ask, whether you define this patient as mild, moderate, or severe, which category she is in.
Ma'am, to
Except one
differentiate,
point which you have already said, that she didn't have any symptoms and now probably she has had started with symptoms and the history, because these findings could be there in a normal pregnant patient in third trimester. So how exactly are you going to differentiate that these symptoms are because of her cardiac history, what she had in previous childhood, like in
Yes.
this childhood time?
Ma'am, symptoms which are very specific to heart disease are paroxysmal nocturnal dyspnea. It cannot be in normal pregnancy. So if patient gives this history, it is very much pointing towards the heart disease. And then again, we will have to see like even with symptoms, if on examination, if there is any diastolic murmur, or if there is a pansystolic murmur, or if it is any murmur which is more than grade 1, that is excluding the soft systolic murmur, we can say that yes, it is pointing towards the heart disease. Also, if there is number of other symptoms associated, that she is having breathlessness, PND, pedal edema together, we can say yes, it is due to heart disease. And also on examination, auscultations.
And on examination?
On examination, ma'am, on CVS examination, the auscultatory findings can be confirmative. Like there can never be a diastolic murmur in a normal patient. So yes, in pregnancy there is hyperdynamic circulation leading to some soft murmur. But that murmur is always systolic. It can never be diastolic. If there is a diastolic murmur, it is always due to some abnormality. Again, on examination, ma'am, other findings of suggestive of heart disease we can rule out, like patient can be having pedal edema, and then increasing dyspnea. And if she is saying that previously she was having a dyspnea after doing some heavy work, and now she is saying that she is having dyspnea after regular activities or even after slight movements, then of course there is progressive dyspnea. That means that there is some cardiac pathology.
Suppose if you are there on the emergency duty when this patient comes in labor, how exactly are you going to manage her? What are the areas when you have to be extra careful?
This patient, ma'am, she is 30 weeks preterm. So, and if she comes in labor and she is in active labor, first, I will take all the history properly, that if she is on any anticoagulant and if she is taking any cardiac medications or other things. And according to that, I will decide the mode of delivery. Since my patient, she is not taking any anticoagulants.
Why this patient will be on anticoagulant?
No, not this patient, ma'am. Any heart patient, so I will take the history of those things. And since she is 30 weeks preterm, so we can, and in heart disease, the preferred mode of delivery it is vaginal delivery. And in preterm labor pain, as 30 weeks, there is no much fetal outcome. So, so what we can do is we will prefer vaginal mode of delivery for this patient. And during delivery, we will during labor management, since she is a heart disease patient, first I'll make confirm that that all the drugs essential for cardiac failure are available at my place, and then only I will decide to deliver the patient here. And in during her delivery, in her first stage, what I will do is I will make the patient rest. I will avoid unnecessary mobility, and I will avoid unnecessary fluid. I will have fluid restriction. I will achieve the IV line, but I will allow her only oral fluids, since in 30 weeks we have no, like, we won't, unless there is any obstetric indications like major placenta previa, and then only we can say of that. But since in this patient there are no any obstetric indication for C-section, what we'll do is we allow her oral fluids. We will secure IV line. We will put her in propped up position, and we will keep the O2 at the side, ready at the side of the patient's bed, and we will give her O2 if required. And then we will monitor vigilant. We will vigilantly monitor the patient, and what we will monitor is we will monitor the vitals. We'll do pulse rate, and then blood pressure, saturation, and urine out saturation, input output monitoring, and also we will see that in her first stage of labor. Hello. Hello.
Yes, carry on, Pallavi.
In our first stage of labor, we will avoid any exertion and stress to the patient. And once the patient goes into second stage of labor, that is full dilatation is achieved, we can do is since she is preterm labor pain, it is obvious that she will likely will deliver in short period of time. In second stage of labor, we will allow her to deliver, and after that in third stage of labor we will do active management of third stage of labor. In her labor, she is already in preterm labor, so there will be no need of augmentation of labor. And after the spontaneous delivery, in post delivery management, we will give her active management of third stage of labor, that is we will give oxytocin IM 10 units. We will do controlled contraction. We will do the intermittent assessment of tone of the uterus, and delayed cord clamping as no immediately we, since the born fetus is preterm, we will do early cord clamping. And then of course we will pre-inform the neonatologist about the preterm delivery with the heart disease patient, and we will then give it to the neonatologist. And after that, in her then we will take her to the HDU. We will keep her in the high depend.
Just a minute. Maybe I might have missed it in between. What uterotonic is of choice?
Ma'am, we will give oxytocin only IM after delivery.
Okay.
Yes,
And did you anywhere mention the role of corticosteroids in this?
yes, ma'am. Corticosteroids, ma'am. She is in preterm.
Labor. She's in preterm active labor, but can it be given, or it is
It can be given. No, ma'am. There is no contraindication. We can give. There is no contraindication. It is always better that we can give. So we will give the steroid coverage, ma'am.
Okay.
And in her post delivery period, as the heart disease patient, they are most prone to cardiac failure at the time of third stage of the labor, or during the
Suppose she was not in active labor and we want to stop her labor.
Ma'am, what we will do is we can give her tocolysis, and we can do steroid coverage, and we will ask the patient rest to we
Which
will do
tocolysis?
Ma'am, in heart disease we prefer atosiban.
Which tocolysis?
Ma'am, in heart disease we prefer atosiban.
Yes.
And
analgesia, do you think it is important in heart disease?
Yes, ma'am. Analgesia is preferred. Analgesia is basically advised in heart disease because it will decrease the stress and pain to the patient, as pain can increase the stress to the patient. So in heart disease, we avoid any kind of stress. So analgesia is preferred. What we can give is epidural analgesia to the patient, and in epidural analgesia, ma'am, we can give pethidine, ma'am, and we can give morphine.
If epidural facility is not available, then what is the second choice?
Yes, ma'am. Epidural is not available, then we can give. Yes, ma'am. Epidural is not available, we can give, ma'am, pethidine. We can give drotin, ma'am.
Drotin?
Ma'am, pethidine, ma'am.
Anything else?
Pain, yes, ma'am.
Can you give some simple like pethidine and other stuff has their own complications.
Tramadol,
So
ma'am.
what is the line of treatment? Like, how do you go ahead one by one if you have to go back and reframe it?
Ma'am, if patient comes with preterm labor pain, so we
Just talking about pain relief.
pain relief, ma'am. We can give tramadol, ma'am.
Hmm?
We will give tramadol, and if even if it is not a relief, and then we will ask patient to rest and rest in left lateral position. We can fluids. No, we will restrict the IV fluids. We will give tramadol. We will ask her to rest in left lateral position. We can give intermittent oxygenation and see if the labor pain decreases. We can give.
Opioids are choice of labor anesthesia in heart disease. What is the added advantage in heart disease?
Ma'am, because they will relieve the stress and also they will increase the heart contractibility. So together they can increase the heart functional status.
Heart contractility? No.
Ma'am, they will relieve the they act as analgesia and they also relieve the stress, ma'am. So we are getting two factors that both of them will be useful for the heart disease patient. Not the contract, the stress and the pain.
It is not related to stress, pain, tachycardia is relief that
Tachycardia,
is there.
tachycardia, yes,
but
ma'am, tachycardia.
what is the effect on pulmonary vasculature?
Effect on pulmonary vasculature due to
Opioids.
opioids.
It reduces respiratory rate and pulmonary capillary wedge pressure. So,
yes. So the
that is the added advantage. And when you are telling vitals monitoring, always include intermittent chest auscultation also.
yes, ma'am.
Why?
Because, ma'am, the patient can at the time of labor or any time, patient is of course prone to go into heart failure, and in that case patient can develop pulmonary edema, and so we can auscultate the basal crepitations and diagnose it early. If we do intermittently, the chest auscultation is done.
Okay, and you told about active management of third stage of labor.
Yes.
Suppose you gave active management and then even then the patient had PPH. What are the points you will take care in mind, which is specific for heart disease? What you will avoid?
Ma'am, for management of PPH, we will avoid ergometry in this patient, because immediately after delivery, already there is sudden increase in the cardiac output, because all the auto transfusion from the uterus is going to the heart, and also the vena cava release is there, so the peripheral blood is also cooling up, so all the preload is already increasing abruptly. And if we give ergometrin in that, ergometrin will again increase the abrupt increase in the preload. So we will avoid ergometrin in patients with heart disease in case of active management of third stage of labor.
And what should be given? Any drug?
Ma'am, we can give misoprostol tablet, misoprostol 1000 in per rectally to these patients. It is safe.
Okay. What about blood loss?
Yes, ma'am. Blood loss.
Can you rush IV fluids in such patients?
Yes, ma'am.
Can you rush
IV fluids? We will restrict the IV fluids, ma'am. We can give 50 to 75 ml per hour. That could be the
IV. If patient has lost blood. If patient has lost blood.
So we will check the blood pressure, ma'am. According to blood pressure, we will give the IV fluids, and we will continuously auscultate the heart, and we can add diuretics accordingly. Since we are giving a lot of IV fluids for the maintaining the blood pressure, we can relatively add the diuretics.
What will be the
so you can give a lot of IV fluids?
Yeah, like, would you like to give IV fluids, or what will be the thing to give?
Ma'am, if the patient has lost a lot of blood, we will prefer packed cell volume for this patient, because since we have to avoid unnecessary load to the heart, so we'll prefer the packed cell volume, and we of course will restrict the IV fluids. Yes, ma'am.
The replacement of blood in high risk patient is only blood. That is
Yes.
why we cross match and keep blood ready for all high risk patients. Okay, in low risk patients, you can rush IV fluid, but in high risk, in such patients, the replacement of blood is only blood. Okay, what are the indications of anticoagulants in any heart disease?
Ma'am, indications of anticoagulants are if there is a patient of the patient of prosthetic mechanical heart valves, then we can give anticoagulants. And if the patient is of atrial fibrillation or there is any history of thromboembolism in the past, then we will put her on anticoagulants. And in that case, in pregnancy, we will prefer and in first trimester, since in first trimester we'll put the patient on unfractionated or low molecular weight heparin from 6th trimester, and that can be given up till 12th week. And after that, we can put the patient on oral anticoagulant, that is warfarin, till 36 weeks. And after 36 weeks, we can again we will start with low molecular weight heparin or unfractionated heparin till the delivery.
Why we are switching to heparin?
Ma'am, because warfarin, it has longer action, and since this patient heart disease patient, they have more chances to go into preterm labor pain, and if the patient is in warfarin, there is more risk of bleeding and complications. So precautionally, we will change the anticoagulants from the 36 weeks, and we will put the patient on low molecular weight heparin.
The
And after
conventional,
it is
the
only
conventional
maternal
one. It is
indication. Yes, no, ma'am. There is fetal indication also, because if the patient is on warfarin and she goes into the labor, and if she goes into the spontaneous labor and delivers, then there are chances of intracranial hemorrhage to the fetus, which is a grave complication for the fetus. And so we will avoid long-acting anticoagulants in near the delivery.
And there are certain other maternal complications which take place if the patient is on anticoagulant. Can you name some?
Ma'am, patient can go into PPH. If second cesarean is if we allow the normal delivery, patient can go lose more blood, and post delivery also patient there can be hematomas. And
yes, more than PPH, hematoma are the more, yes, the incidence is more, because PPH you are aware about that this can happen, so you are at your toes. But once you don't look at the episiotomy, the patient can come back after 2 hours with episiotomy hematoma. This is same even with cesarean section. Skin hematomas are also very common in these kind of patients. So one needs to be very careful when you are putting the sutures. If there is any doubt, it is always better to leave a drain. The drain can be taken out after 24 hours if there is a need.
yes,
In postnatal period on day 1 or day after 24 hours, if you visit her in HDU, what all things you will check on your rounds?
Ma'am, we will first see the vitals. We will take pulse rate, blood pressure, saturation, respiratory rate. After that, we'll see we will see, of course, we'll see the temperature of the patient, and then we will check the uterine tone, involution. We will check the uterine tone, and then we will check the perineal area for any hematomas. As ma'am said, we will check that. We will see if we will see the lochia, and we can see the input output. We will see the input output of the patient, and we will ask the patient that if she is having any symptoms or any discomfort or any breathlessness or any dyspnea. And we will also see that if she is regularly feeding breastfeeding, we will see the neonate also. And then we will also explain the patient that there is any slightest discomfort should be noted and told.
What contraceptive advice will you give her?
Contraceptive advice for the patient, ma'am, we can put her on progesterone only pills, and we can advise, we will give options of progesterone only pills, or we can also give LNG IUDs to option of LNG IUD to the patient, ma'am. Since OC pills are contraindicated, since they will increase the risk of heart disease.
And how about Antra or depomedroxyprogesterone? Will that
yes,
be
ma'am.
your
Yes,
choice?
Implants also can be done, or Antra can also be given advice.
Madam, any other questions?
Suppose same patient comes to you after 3 years and she's planning next pregnancy. What all things you will check before for pre-pregnancy?
If pre-pregnancy, we will see. First, we will see if there is. First, we will see about the cardiac status of the patient. So we will only advise the patient when the cardiac, when the heart, there is no compromise in the heart. So first, we will check about the any symptoms she is having after the delivery or at present. So first, we will ask her to do the echo and other investigations, and if there are any things suggestive of that the heart is not fit, then we will first correct those things, and only when the patient is having no symptoms and she is comfortable, then only will allow her for the next pregnancy. And we'll
Suppose
also
if
see if
she
there also
Suppose
see
if
that
she doesn't
her
come to you. Madam is very positive in thought, like coming to you pre-conception. Suppose if she doesn't come to you pre-conception and she comes to you conceived 6 weeks or 8 weeks, what will be the role of termination? Would you like to go ahead with termination, or would you ask her to continue the pregnancy with a rider? What is it?
ma'am, first she will come to me after pregnancy, I will first see about the see that what is the status of the patient and what classification is according to NIHS she is belonging to. I will do WHO risk classification, and I will see if there are any other risks. And if the patient is all comfortable and she is fit and belonging to NYHA 1 or 2, I will allow the pregnancy. But if she is already having symptoms and she is in NYHA 3 or 4, I will advise her that specifically if she is in NYHA 4, I will ask her to terminate the pregnancy. And since she is 6 weeks, it is the ideal time because we can go up to 12 weeks. After 12 weeks, MTP is not allowed is not advised in case of heart disease patients.
You
Because
did
after 12
mention
weeks,
about the risk assessment score. What is it called as?
Ma'am, it is modified WHO heart disease pregnancy in heart disease risk assessment score, ma'am. There are total 4 groups, and there is overlapping of second and third group. According to each group, the WHO has given their management plans and follow-up plans accordingly. And in WHO 1, there is WHO 1. There are atrial septal defect, mild or small atrial septal defects, ventricular septal defects, or patent ductus arteriosus, and repaired phallus, and repaired ASD or VSDs in WHO 1. In case of WHO 1 classification, they say that there is not much increased risk and pregnancy can be allowed safely. And in that case, you have to get the cardiologist opinion once or twice in the entire pregnancy, unless there is any discomfort. And then and we can allow the delivery at local hospital according to modified WHO. And in WHO classification 2, what we say is in WHO classification 2, there are unrepaired small ASD, VSDs, and PDAs. And in that case, WHO2, that also we say that it is safe and we allow the pregnancy. Just we have to increase the frequency of cardiac expert opinions, and that is monthly, every trimester. Every trimester we have to get the cardiologist opinion, and there are more frequent visits. And even in WHO2, we allow the delivery at local hospital. In the overlapping of 2 and 3, there are more frequent visits. That is bi-monthly we advise patient for cardiac opinion, and we allow delivery only at the expert centers. In WHO 3 classification, in which there are cyanotic heart disease, in that cases we allow we tell them to advise them that pregnancy is not preferred, but if the patient is insisting, in that case we will tell bi-monthly follow for the patient and delivery at expert center. In WHO 4, the pregnancy is contraindicated. They do not advise pregnancy. Even if the patient gets pregnant, it is said that you should MTP is advised till 12 weeks. After 12 weeks, they say it is same, the risk is same for continuing the pregnancy, even for medical termination of pregnancy. In WHO 4 classification, the like Eisenmenger syndrome, and then aortic coarctation of aorta, and severe aortic stenosis, Marfan syndrome with dilated aortic valves, all these diseases are there. And yes, the pregnancy is absolutely contradictory.
Severe pulmonary
Severe pulmonary arterial hypertension. Yes.
Good.
So we will risk stratify that patient, and according to that, we will tell her whether she is pregnancy is to be continued or not.
any cardiac drugs which are contraindicated in pregnancy?
Yes, ma'am. There is antiarrhythmic drugs, amiodarone, which is contraindicated in pregnancy.
Any antihypertensive?
Yes, ma'am. ACE inhibitors and ARBs, they are also contraindicated in pregnancy.
So we should check before pregnancy if she's taking these
We will
drugs.
check all the drugs the patient is on and the anticoagulants, and we will likewise we will tell her how to modify the drugs.
Dr.
Considering all the
Pallavi, you have answered really well. Whatever is expected from postgraduate, you have answered everything.
Thank you.
Really, she has
Thank you
put
so
a
much,
lot of
ma'am.
effort.
Thank you, ma'am.
Yeah.
Good
Thank
job.
you so much,
So
ma'am.
wonderful,
job.
huh, Pallavi?
Thank you so much, ma'am.
Good job.
Jabardast. Just like I was constantly, really, she's giving answers to all.
उसने मैडम दिल को अपने काबू में कर लिया है.
Yes, dil ka kaun.
No, ma'am. Lot
She's
to
a
learn,
good
ma'am.
she's a very good student of our college, madam.
Thank you, ma'am.
Great, madam. Great.
And Kshama, then Dr. Rajni, all prepared her very nicely.
Yes, ma'am.
Yeah,
All
that's-
It's
yes,
her
the
own
guidance of
effort, madam.
no,
We
no,
can
ma'am. Of
tell
course,
them.
ma'am has given a great guidance.
We can only tell them, but their own efforts are very important, and
Yes,
she has
yes.
really prepared it very nicely. I'm so proud of
Very
her.
nice.
Thank you, ma'am.
Yeah.
Thank you so
Very
much,
nice,
ma'am.
Pallavi. All the best for
Absolutely.
your exams.
Thank you so much, ma'am.
Absolutely. Great job.
Thank you, ma'am.
So whatever is asked, she has,
Just answered, fired.
answered also, and the presence of mind is very good, and immediately she has collected all the points from history, examination, everything.
It was very nice presentation, Anjali, Dr. Pallavi. And really, we can see how Dr. Shama is reflecting in Pallavi's presentation and how good teaching is.
Thank you so much, ma'am. That was a great compliment.
So
Thank
we
you.
are
ma'am.
really so proud of Dr. Shama, Dr. Pallavi, and all the team. I just wanted to ask one thing, if the examiners permit. You mentioned that she was on penicillin prophylaxis, isn't
Yes,
it?
ma'am.
Anna? So
Yes,
what? Just can you add a word about that, like how the prophylaxis is stopped, and even after labor, after delivery, does she require?
Ma'am, we give injection penicillin, benzathine penicillin, 1.2 mega units every 3 weekly, and it should be given throughout the pregnancy and in the puerperium, because at that time patient is at highest risk of infection. So we don't stop the prophylaxis. It is much needed, ma'am.
You ask her any question, answer is always
She
there.
will answer back.
Please, yeah.
Yep.
Cut, challenge.
Very nicely
Thank you.
present.
So congratulations, Pallavi. Great.
Great job.
Thank you so much, ma'am. So cardiac disease of pregnancy encompasses a broad arena of pathologies. Thank you so much, all the madams. We had a wonderful discussion and lots of take-home messages from you.
And thorough discussion we had.
Yeah, exactly.
And I was
Yes,
listening,
really
both the examiners have asked very nicely and pertaining to the case, and they have answered it itself very nicely, Pallavi. And all the examiners, I congratulate you. And
You're
I
very-
Thank you, madam.
Shishma
Madam,
and
हमने pass
Anjali,
हो गए.
Dr. Avantika, really wonderful. You are asking so
both
nicely.
the
and
examiners,
Really, we also got so many
fantastic
things. new.
examiners.
Really.
Very wonderful
nice.
examiners.
Yeah.
Thank you.
Kanhere ma'am, I'm your student from GMC Bhopal only.
Oh, that's great. That's great.
Oh my God, there are 3
Very
GMC
nice.
Bhopal sitting here. There are 3 GMC Bhopal. Me too, GMC Bhopal. No, sir.
Even
Anjali.
No,
Oh my God.
Pragati is also from GMC Bhopal.
Bhopal.
Yes.
Oh my God.
Bhopal
Wonderful,
dominating.
wonderful to know you.
Thank you, ma'am.
So good, so
But
good.
Rajni is now my Yavatmal.
Really, Shama madams.
I have full this thing on. She's a fantastic teacher also, very good doctor also.
Thank you, ma'am. So we proceed with the next session.
Yes.
So next session is Pearls of Wisdom. For this session, the chairpersons are Dr. Shama Kedar ma'am and Dr. Manoj Chilani sir. So as we all know about the Shama Kedar ma'am, she is MBBS MD, FICOG, FIC MCH, professor and head of the OBGYN department, Yavatmal, and president of Menopausal Society, Nagpur, vice president NOGS 22-23, PG teacher since last 30 years. She has developed unique workshop on the pelvic anatomy, revisited, and evidence-based cesarean section. author of the book Pelvic Anatomy Revisited Clinical Application, and editor of the book Practical Approach to Menopause Management. She has received many awards, and one of them is a MS Signature International Award for phenomenal leadership in advocacy and branding of PPH. Won first prize for the paper presentation and gold medal at 31st AICC RCOG 2017, and special interest in pelvic floor anatomy. And other speaker is Dr. Manu Chelani, sir. He is MBBS DGO. You just tell us on the slide. MBBS DGO from JLMMC Raipur. And he Best IVF Baby Center in 2015. I think sir is here. Sir is present. Manoj sir. Okay. Our speaker is Dr. Anisha Gala. She is DGO DNB OBGY Fellowship in Obstetric Medicine, Senior Consultant Obstetrician in Pandanas Hospital in Hyderabad, and the area of interest in the medical disorder, complicated pregnancies and labor ward management and pre-pregnancy counseling. So today's topic is on understanding heart dilemmas in pregnancy and their management. So now hand over the mic to Anisha Gala, ma'am.
Yes, thank you. Thank you so much, Doctor, for introducing me. I'll just share my screen if you stop sharing your screen.
Yes, ma'am.
Pallavi, you should stop sharing your screen. Then I can share my screen. Karu? Yeah.
Madam, you upload your screen. Our screen will disappear.
Okay. Yeah. Can you all see my screen now?
No, 1 second.
But Pallavi, you can just
Uh,
Stop sharing screen, Pallavi.
there will be where you have put,
yes.
Yeah.
Yes.
Are you able to see my screen?
Yeah, we can see.
Yes. Yes. Thank you so much. And can you see the slides moving? Are
Yes,
they
sure.
moving? Yeah.
Yes.
Yeah.
Yes, good. So I must thank the organizers from Nagpur OBGY Society to invite me for this talk. Heart disease is close to my heart. I love talking about it. My job is done easy and difficult both at the same time by Pallavi. Because she has said everything, there is nothing much to say. It is just revision of whatever she has said. Difficult because there is nothing much to say. I don't even know what I should add extra to what she has already said. So it might be boring revision or whatever for you all, but let's see how we go about it. So we all know that with heart disease and with people people surviving a lot of medical problems in their childhood and in neonatal period, these all are now grown up and becoming patients of obstetric population. There is rising incidence of grown-up congenital heart disease, more so complex congenital heart diseases, which are corrected nowadays. So it is called as GUCHD, grown-up congenital heart disease. There's a separate entity in itself, and we all should be aware that there are cardiologists who take care. So they are pediatric cardiologists who follow them up till childhood, teenage, and then into adolescence, and then period after marriage. So they are the ones who take care of it, but they should have special interest on that, because once the complex congenital heart disease is corrected, the hemodynamics of this heart disease change. And that we should understand. So we should be aware of this fact. Of course, rising incidence of maternal age, background risk factors such as hypertension, diabetes, obesity, and all that. And so it is not unusual to find a woman with a history of myocardial infarct or acute coronary syndrome coming with pregnancy after she has tided over that crisis of acute coronary syndrome. So these are all they are all at high risk of obstetric maternal morbidity. So when we look at incidence in Northeast India, there's 1 or 2 journal which talk about incidence overall in India, but really it is very difficult to find incidence in India about the categorization of heart disease. Most of the now rheumatic is going down and congenital is going up, and corrected congenital or grown up congenital heart disease. So they are called as they have dual problems. Congenital heart disease like cyanotic, and then they are corrected, so the hemodynamics change. So now we have to think differently once they are corrected. So this is roughly the incidence of less than 5%, but almost 50% of congenital and rheumatic. We all know we should be aware of cardiovascular changes in pregnancy. We all know that cardiac output increases, heart rate increases, blood pressure, the systemic peripheral resistance decreases, and plasma volume increases. All this puts at heart to so much of cardiac preload, afterload, everything is there. And so we must be aware of what the lesion will demand the heart to do. Suppose there is mitral stenosis, how will the heart react to that? Suppose there is mitral regurgitation, how will the heart react to that? Suppose there is, ASD or VSD or Eisenmengerization, what is happening to the heart? So always, as postgraduate students, we should draw what is happening. Unless you draw the lesion and think about hemodynamics, it is very difficult to assess what the lesion is, what the pregnancy is doing to the lesion. So primarily our aim should be to keep mother safe, only then the baby can be safe. So if you understand what the pregnancy is doing to the lesion, you will know the rest of the things can be figured out. So this is the same slide about hemodynamic changes in pregnancy, which increases the plasma volume tremendously. And that is why the heart rate increases, the cardiac output increases, and peripheral vascular resistance is decreasing. So these are, suppose it is mitral stenosis, the physiological changes of pregnancy further aggravate the hemodynamic consequences. If it is mitral stenosis, this is an example that I have taken because that is the most common thing that you will see in your exams. So there is decrease when there is increase in heart rate because of the increased demand, because there is a stenosed mitral valve, there is very less blood going out from the left ventricle into left atrium into the ventricle, and so there is tachycardia to cope up with the demand. When there is tachycardia, there is very less diastolic filling time, so there is no diastolic filling time, and so tachycardia is bad in most of the heart diseases. We must realize that tachycardia is bad. Why there is dyspnea, orthopnea, PND? These are a sequence of events. We all should understand that any kind of heart disease, it is because of either cardiac overload or there is flooding of lungs. There are two things. So flooding of lungs can be because of restrictive lung pathology in itself, which also, like suppose there is already pulmonary arterial hypertension. Normally there should be no hypertension in pulmonary arteries. I mean, the blood pressure should be very less in pulmonary arteries. But if there is pulmonary arterial hypertension, it is like a very, very high risk condition for the woman. And with rest or with lying down flat when there is flooding of lungs, or if there is dyspnea because of increased physical activity, these are all indications of non-compensated cardiac disease. So there is no, because like fixed output states such as aortic stenosis or mitral stenosis, there is a stenosed valve which is fixing the output. The heart cannot, in one ejection fraction is very less. The ejection cannot be there. There is no fixed cardiac. There is a fixed cardiac output. It cannot increase beyond that. Then when there is increased demand, like in physical activity, the heart fails. So the heart cannot, and the only way it has to respond is by increasing its heart rate. So if it increases its heart rate, there is no preload because it is like there is no diastolic filling time. So it's a vicious cycle which develops on its own. So look at this lady who is a primigravida. Something very similar to what Pallavi has presented, but whenever we have a case, we can discuss it much more in detail. She has come to us with ER visit at 21 weeks with shortness of breath, with cough, waking up in the night with breathlessness, and after becoming upright, she's feeling better. JVP is raised. There is mid-diastolic murmur in mitral area, ejection systolic murmur in pulmonary area, end diastolic murmur in aortic area, and in tricuspid area. So there is mitral stenosis, NYHA2, with aortic regurgitation and NYHA2. What are you going to do for her? Oh, sorry. This is not moving. So how do you identify a cardiac high risk factor in the cardiac case? The golden rule, there is no running away from that. You may do a 2D echo, you may do any other 100 investigations, but primarily if you cannot examine and you cannot examine all systems, then your efforts are a waste. So look for scar sinuses, look for JVP, look for other symptoms. They will tell about signs of failure if there is hepatomegaly or pedal edema, and they will tell you, and of course her symptoms, they will tell you you don't even need a 2D echo. 2D echo will only confirm your diagnosis. If there is any visible impulses or scar that is suggestive of previous surgery, if there is apex beat that is moved away, parasternal heave, thrills are there, auscultation will tell you so many things. So Pallavi has mentioned all these things in her examination so much in detail, so I will not dwell on it so much. So what is the rule of 2D echo? It will tell you what is the diagnosis of the valvular lesion, what is the anatomy access, what is the anatomy of valve, whether it is amenable to any corrective surgery. In pregnancy, can I do a mitral valvulotomy or can I do a mitral valve replacement? Because if it is a fixed, thick, calcific mitral valve, it is not amenable for valvotomy, balloon valvoplasty or valvotomy. If there is presence of hypertension and if there is any other cause of breathlessness, suppose there is cardiac effusion or tamponade or pulmonary embolism or sudden cause of breathlessness, that is if there is change in murmur and there is a thrombus sitting on the valve. So whenever in any cardiac lesion, if there is a change in murmur, we all have to be really, vigilant of this fact that there can be a thrombus sitting on the replaced valve or on a deceased valve. So these all things are, so whenever you look at 2D echo, just don't look at the mitral valve area or look at the left ventricular, left atrial dilatation, whether the mitral stenosis is increasing the left atrial dilatation. Is there any pulmonary arterial hypertension? How will you look for pulmonary arterial hypertension? You will look for it by looking at right ventricular systolic pressure, the amount of systolic pressure the right ventricle has to initiate to send the blood to the lungs. So that is a reflection of pulmonary arterial hypertension. Are there any lesions? Is the chordate, suppose there is mitral regurgitation and mitral valve prolapse. So what is the reason? Is there any chordate tendon rupture and that is why there is mitral valve prolapse? Or the mitral regurgitation is because of the only posterior valve leaflet collapse, loose posterior leaflet because of loose chordate tendon, that is posterior leaflet prolapse, or is it a stenosed or a calcified posterior leaflet, or is there is a vegetation on the posterior leaflet or anterior leaflet? So what is the cause? It will directly tell you about the pathology. And what are the red flag symptoms should we look at for each visit? In antenatal review, we should always pay attention. So every antenatal review should mention NYHA class. Ask about fever, if there is any sign symptoms of any infections anywhere. Is there any dyspnea or there is any worsening of dyspnea? If there is any rapid weight gain, swelling of hands and feet, if there is any new onset cardiac complaint, change in murmur, if there is anemia, which again puts load on the heart. So patient education is of utmost importance. So whenever you do an antenatal review, you must educate her of these symptoms, right? And give her that if these are your symptoms, you should immediately report to the emergency room. And so well documented detailed plan should be there. And as we approach term, you have to put her pregnancy, you have to put her labor plan in detail, whether you want to induce labor or you want to await spontaneous onset of labor. Till when do you want to await spontaneous onset of labor? All that has to be well documented in any cardiac case. And where is she going to deliver? Who is going to assess her? Whether who are the members of the multidisciplinary team who are involved in her care, who should be informed. In a big institute, when you are working, you all should document it properly as to who should be called for this woman who comes in labor. So 2D echo, you can see that it showed severe MS, that is critical MS. Mitral valve area was 0.8 centimeters square. Anterior mitral leaflet is doming and posterior is restricted, and that is why there is mitral stenosis. There is regurgitation because one is doming and another is restricted. Both the leaflets are gone. Aortic stenosis is there, and mild tricuspid regurgitation is there, which says that there is so much of pulmonary arterial hypertension. And so now from here we can understand that there is a double valve disease. So what do we do now? Now there is a double valve disease. What should we do? So how do you classify or quantify the risk? There are few risk factors. which should come into place. Of course, the ideal situation is to have a pre-pregnancy counseling for these women, but let us look at the assessment of risk when they come. So how do you assess the risk of these women? NYHA will tell you a symptomatic class. Symptomatic class will never tell you the lesion. So it is depend on symptomatic class. So for postgraduate, you must remember these words: CAR-PREG, Zahara, and WHO. So CAR-PREG, Zahara, these are systems of risk quantification. When you look at CAR-PREG study, these are the predictors. Suppose there is systemic ventricular impairment, which means LV dysfunction, left ventricular dysfunction, or there's a prior cardiovascular event like a cardiovascular collapse or cardiovascular, what you say, she has had a heart failure in previously, more than 2 NYHA class, or presence of cyanosis or left heart obstruction like aortic stenosis or aortic double aortic valve, or so aortic stenosis or hypertrophic cardiomyopathy with aortic obstruction. So these are the predictors from CARPEG study which tell you that she is at very high risk of having a cardiac failure or death in pregnancy. And Zahara study, these are the events. You all should take screenshot of this. You all, so these are the risk factors from Zahara study which will tell us. But the problem with this is they still don't tell us what to do. So what did WHO do? WHO, as Pallavi has very, very clearly stated, that there are few, these are the lesions which come in WHO class, modified WHO class, where they say that the risk is unlikely, she is unlikely to have any problem, which means 5% of risk is there, but 95% there is no risk. Counseling should be there, and care during pregnancy and delivery can be in local hospital. 2, you should, so easy to remember is 1 and 3. 3 is, these things where you say that these are the lesions, and yes, you should deliver her and have pregnancy care, I mean antenatal care in a hospital which has gynecologist and cardiologist 24/7 care. 2 is easy, all these unoperated lesions, still you can take care of these people in the local hospital. Between 2 and 3, you should, any doubt, it is always better to upgrade the lesion than downgrade the lesion. You send her to a cardiorespiratory, cardiac center, to a center with cardiac backup. So 2 and 3, these are the lesions. Very easy. You all should put up the poster in your posters in your antenatal OPD so that it is easy for you to remember. And 4, where pregnancy is clearly contraindicated. But if they come with pregnancy, yes, you should, before 12 weeks, you should ask for termination in pregnancy, termination of pregnancy. After 12 weeks, the risk of carrying pregnancy versus second trimester termination of pregnancy is equally life-threatening to the mother. So with good backup, with good rest and whatever needs to be done for the lesion, you may do it and carry the pregnancy and deliver as you reach the viability. Ideal time to deliver these patients is at 34 weeks. If you're in ICU, you can take care of them. Now, the question to all the postgraduates is, and Pallavi especially, is which is the lesion which is not described here in MWHO? If Pallavi can unmute herself and tell.
In WHO, which ma'am? Which class?
Any class. In MWHO, one lesion is not mentioned.
Mitral stenosis, ma'am?
It is there.
Lesions.
It is there.
Stenotic lesions.
Mitral valve prolapse, stenosis. So yes, we should not waste so much time because I have been given only half an hour. So acute coronary syndromes, arrhythmias are also there, but acute coronary syndromes, see, severe MS is there in 4. Acute coronary syndromes and patients with MI, you don't know where to categorize them, but it is advisable to categorize them in 3. So you because these are the people with which can have sudden, like they are at almost 20% risk of having a cardiac event during pregnancy. So mitral, myocardial infarction, history of myocardial infarction or myocardial infarction in pregnancy, and second is with women with history of acute coronary syndromes, ACS. These are not classified anywhere in MWHO. So we should remember that. And this is again for postgraduates and all people who are considering taking care of women with cardiac disease. There is something called as ROPAC registry, Registry of Pregnancy and Cardiac Disease. We all should We all should compile our, this is an online registry. This is a, it has described the outcomes of women who have had cardiac outcomes in pregnancy, and most of the guidelines, like there are guidelines, I will come to it at the end of my talk. There are guidelines from European Society of Cardiology, ESC, European Society of Cardiology, and AHA, American Heart Association, which have come from this ROPAC, which said that women with mild and asymptomatic mitral valve disease tolerated pregnancy well, but mitral stenosis was less well tolerated than mitral regurgitation, because in regurgitant lesions, when the peripheral vascular resistance is less, like there is no resistance in the periphery, the regurgitation into the heart is less, so the blood will flow out of the heart. There's no regurgitation, so they tolerate well. Whereas in stenotic lesion, it's a fixed cardiac output state. It's a very dangerous state. Cardiac output should never be fixed, because it should increase and decrease as per your physical activity and the demand of your physiological demand in pregnancy, whatever is happening, right? So it should increase and decrease. What is there? And rates of heart failure were highest in severe mitral stenosis and moderate mitral stenosis. Again, they have talked so much about mitral stenosis that according to them, mitral stenosis should be in 3 and 4. Yes. So these are the findings of ROPAC. You all should see ROPAC registry is that the paper is freely available on the internet. Of course, fetal risks of miscarriage, stillbirth, fetal growth restriction, prematurity, teratogenicity because of drugs, bleeding if they are on anticoagulants like intrauterine bleeding. So whenever you are doing an ultrasound, you have to look for fetal bleeding disorders, like suppose a space occupying lesion in brain or a translucent area in the intracranial translucent area lesion. You should think that she has there is an intracranial bleed for the baby because of warfarin, if she's on warfarin for her medical condition. And if they are in the mother is a woman with congenital heart disease, inheritance risk is 5% for mother, and 10% if it is 5% if it is father, 10% if it is mother, 20% if both partners. Yes. So that way you have to counsel them about inherent risk of congenital heart disease. So a woman with congenital heart disease, ASD, VSD, PDA, etc., they must have a targeted fetal echo at around 22 to 24 weeks of gestation. Of course, screening 2D echo will be done during screening fetal echo is done during TIFA scan, but targeted echo with all those cardiac axis and so many things, they take measurements, that should be there for these women. So our woman, because of her critical MS, underwent PBMV at 26 weeks, and then her symptoms got relieved, and anemia was corrected with oral iron. We all should be aggressive in correcting anemia for these women. This was the fetal growth evaluation. We evaluated her. In 37 weeks, she came in spontaneous labor. She had IE prophylaxis because it's a double valve disease. So this is the protocol we follow. So everything is written there. So you just have to tick, 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 so that so whenever you are working in a big institute, you should have such protocols so that nobody does what they want and nothing is forgotten. You know, when it's a big team, it's very easy to forget things, and to have all team levels work at the same level, you should have a set protocol in place so that nobody misses anything. Of course, outlet forceps delivery in ICU, outlet forceps delivery for maternal indication. We don't want her to bear down. And then, of course, she went on to have postpartum thromboprophylaxis. So what are the indications of delivery? This is ESC guideline at 40 completed weeks. Obviously, you don't want any heart disease to go post-date. Depends on the cardiac status. Like suppose we have done something to her and she's having recurrent pulmonary edema and cardiac failure events, flash pulmonary edema. Then you deliver them once you reach the viability. So what is the agent you want to use? Avoid, aim for mechanical methods, avoid, prolonged labor, infection, dehydration, tachycardia, ensure that there is some pain relief. And cesarean, of course, is for obstetric indication only. Or if woman is in labor on OAC and the traumatic delivery is expected, fetus is very big, then it is not wise to allow this woman to have a labor, because there is so much of risk of fetal intracranial hemorrhage. Medical care, yes. The role of medical management is limited to obviously symptomatic relief. Ventricular rate has to be controlled if they go in atrial fibrillation. Prophylaxis is there for rheumatic fever or RHD penicillin as Pallavi. Infective endocarditis prophylaxis, there is a good guideline for infective endocarditis prophylaxis and anticoagulation. So reduce your preload, ensure that diuretics are given for them. Heart rate control is important because we said that it is important to have some diastolic filling time. Use beta blockers whenever indicated. And if they are in atrial fibrillation, urgent cardioversion is recommended if they are hemodynamically unstable. Amiodarone is contraindicated in pregnancy, but other things like medical cardioversion has to be done rapidly because it is very easy for them to tip the scale and go into failure. So what are the indications of intervention? If the mitral valve area is very less, or there is progressive MS, or if there is consistent pulmonary edema or going into flush, any cardiac, whenever they are going into cardiac failure, then you should do these interventions. So percutaneous balloon valvotomy can be done in pregnancy, open, you may do it, and closed, you may do it, but what is the treatment of choice nowadays? Closed balloon, like percutaneous balloon valvotomy. Mitral valve repair and mitral valve replacement are reserved for later stage. What are the indications of infective endocarditis prophylaxis? It's very easy. This has to be there in the labor room. We still have this chart in our labor room, or on the B side of that form that I showed you, there is, you tick the indication, tick the antibiotic, and it is given by sister. So whenever in doubt, please give infective endocarditis prophylaxis. We had a woman who had infective endocarditis despite the prophylaxis, and she had a infective embolus. Then infective embolus can migrate anywhere and cause so many other problems. So she had an infective embolus, and for them embolectomy had to be done. For her, embolectomy had to be done. So we have to be careful of these women in postpartum state. If there is any change in murmur or sudden onset of breathlessness or sudden onset of symptoms, that is there a thrombus or like a clot on the valve or infective thrombus, infective embolus on the valve. So what is there, we have to see. Indications for LSCS, yes, if there is any aggressive aortic pathology or intractable heart failure or severe forms of pulmonary hypertension, or if a woman is in advanced labor on oral anticoagulants where traumatic delivery is anticipated, you must do a cesarean section. These are the cesarean sections for cardiac cause. Of course, other reasons for cesarean section are when you are having any obstetric cause like previous cesarean section. You won't give a VBAC for this lady, isn't it? So breech presentation, you won't give any breech delivery, vaginal breech delivery for these lady. Intrapartum propped up position, left lateral position, optimum hydration, vitals monitoring. If possible, you should do continuous cardiac monitoring. There are good cardiac monitors which monitor heart rate, pulse rate, cardiac output monitor, SpO2 monitor, everything. You just put a probe and everything is intra-arterial, intracath they introduce, which will monitor intra-arterial blood pressure, and so everything can be monitored. Auscultate chest, give good pain relief, good antibiotic, ensure good input-output chart is maintained, pulse oximetry is done, vaginal examinations have to be restricted because asepsis is very important, and FHR monitoring. And ensure that you do a timely cesarean section in controlled conditions rather than, doing a crash cesarean section when there is severe bradycardia or severe like cord prolapse or abruption. So if there are any additional risk factors such as preeclampsia, then you have your threshold low for cesarean section for such women. With heart disease, with preeclampsia, you don't want any more problems, isn't it? Second stage, continue monitoring, avoid Valsalva maneuvers if they are decompensated, and cut short the second stage. In third stage, oxytocin, diuretics, frequent chest auscultation, because we all know that these are at risk of cardiac failure in third stage once the placenta is delivered, because almost 1 to 1.2 liter of blood in a full term uterus is siphoned into systemic circulation. So the blood flow to a normal non-pregnant uterus is 50 ml per minute. You all should remember that, 50 ml per minute. In a full-term pregnant uterus, singleton, the blood flow is almost 900 ml to 1 liter per minute. So as the uterus contracts, all the blood is thrown into the systemic circulation and there is sudden increase in preload, and now the cardiac output has to increase, isn't it? But in women with fixed cardiac lesions such as mitral stenosis or aortic stenosis, there is no, it is a fixed cardiac output, so there will be tachycardia. Heart cannot take that because it has to beat faster to take all that preload, so it cannot beat faster. It can beat faster, it cannot increase its output. So if it beats faster, then there is no diastolic filling time, and so ensures the cardiac failure. So in this third stage is the most crucial stage. So that is why you should give diuretic, so that the extra volume, the blood, extra volume that was there should be driven out of the system. Yes, so we all should remember that. Madam, it is 8:32. Can I just take 5 more minutes?
Carry on.
Yeah.
Carry on, please.
Yes. Anesthesia, yes, there are anesthesia concerns with these women. There are anesthesia concerns in these women. It is important to have good analgesia during labor because it blunts hemodynamic alteration and pain and the response to pain. It reduces heart rate, blood pressure, and overall there is increase in cardiac output and oxygen consumption. But if you are giving them spinal anesthesia or the anesthetist is giving epidural anesthesia, then it is important to not have sudden hypotension, you know, that full dose spinal and there is a sudden hypotension, because you can't even overload this patient. Preload of before spinal anesthesia should be avoided. They should co-load, and the so much looking at the patient's blood volume only, I mean the weight of the patient only, you should increase the blood volume and do the preload before giving spinal anesthesia. So slow dose titration or slow graded epidural it is called as. So preferable is graded epidural. So don't put anesthetist in a situation where there is cord prolapse and now you have to urgently deliver the baby. No, it is very dangerous for the mother. You cannot save the baby, putting mother's life into danger. A word on contraception. We all know that, like Pallavi said, yes, what she said was correct. But as a postgraduate, we expect you to talk about medical eligibility criteria. So, yes, so medical eligibility criteria, this word has to come out of your mouth. Otherwise, and then category 1, 2, 3, 4, and whichever category suits it. So obviously, combined OC pills are out. Either they go with DMPA, implant, IUCD, or LN intrauterine system. Of course, barrier is recommended for them. Barrier is recommended for everybody, but correct, consistent, and constant use has to be there, isn't it? The 3 C's for barrier contraception have to be there. So you must talk about WHO medical eligibility criteria when you are talking of contraception in exam for all kinds of contraception in all kinds of medical disorder. You can't say I will allow this and not allow this. No, you said medical WHO medical eligibility criteria. What about emergency contraception? For emergency contraception, copper IUCD is effective because it gives you 5 days of that window period. Otherwise, 1.5 milligram LNG is given, or as long as you are not giving estrogen, the other forms of contraception, emergency contraception, are allowed in these women. So it is important to have something called as cardio obstetric model of care, where there is a team of anesthesiologists, nursing, social worker, other specialists, cardio obstetric experts. You know, there should be a cardiologist also who should be who should understand the hemodynamics of pregnancy and who should understand to give us the inputs. You shouldn't have somebody who just writes metoprolol or propranolol. But what does it do to the baby? So like that, you should have somebody who is very efficient in, who is interested in obstetric patients. And of course, there should be a maternal fetal medicine expert who should understand, suppose the woman has conceived on warfarin, or suppose the woman is on something like digoxin. There are digoxin effects on the baby, isn't it? So all that, they should also be able to give us any inputs. So with the obstetrician who is keenly interested in cardiac lesions in pregnancy, there has to be it has to be reciprocated with cardiologist, fetal medicine expert, anesthesiologist who are equally interested in taking care of pregnant women with cardiac problems. Okay, so these are the guidelines. It is there in AHA. I don't want to go through it because it is there in paper. You all should read that guideline. You cannot go for exam without going for without reading this guideline. This is again given in that the same guideline that if there is any emergency for these cardiac patients in pregnancy, what should you do? Suppose there is group A streptococcus infection or acute rheumatic fever, recurrent rheumatic fever or rheumatic heart disease. Everything is given there. You have to follow what the guidelines is. That guideline is very beautiful. A word on anticoagulation. She is the woman who had with the prosthetic valve in situ. The problem with prosthetic valve is that the problem with anticoagulation, whereas because the complications of anticoagulation, excess anticoagulation is bleeding and undercoagulation is thrombotic valvular disease. So this is again was discussed earlier. What are the indications of anticoagulation apart from mechanical valves in pregnancy in cardiac disease? Paroxysmal or permanent atrial fibrillation. When there is atrial fibrillation, we must understand that the heart, the atrium is having, it is fibrillating. It is not having a good contraction. There is stasis of the blood in atrium. Stasis causes thrombus. So that is why in atrial fibrillation, you must give anticoagulation. So atrial fibrillation of any cause. Left atrial thrombus, any thrombus, yes. Prior history of embolization and LV systolic dysfunction. These are the indications for anticoagulation apart from mechanical heart valves. Another important thing here, which I did not forgot to mention, is dilated left atrium more than 4.5 centimeters square. So if the left atrium is dilated, it is another reason for anticoagulation, because it will never empty completely into the left ventricle. So there is always some stasis of blood. So dilated left ventricle, left atrium, atrial fibrillation, and of course thrombus and other things. Yeah, LA dilatation. I've mentioned that, yes, but the millimeters I did not write. 45 millimeters and more. You all should remember that. So prosthetic heart disease, heart valve, the risk depends on type and function and position of the valve, cardiac function, and patient symptoms and functional capacity. Other risk factors we all should see. You can see that these are the risk factors. If they are older generation valves which have too much of tremendous of yes, there is too much of turbulence of the blood. So it has to be just, the ball valve and the cage valve. These are all very, very traumatizing and very much thrombotic generating valves. Whereas the leaflet valve, the fish valve types are simpler and easier valves. Okay, so we all should remember that. Delivery, we should give therapeutic LMWH. If they are on therapeutic LMWH, omit the dose 24 hours prior to cesarean and restart 12 hours postpartum. If it is a planned vaginal delivery, but if they are at high risk of thrombosis, like suppose there is double valve, we had a patient with mitral valve replacement and aortic valve replacement, she's at high risk of thrombosis, then you give continuous infusion of unfractionated heparin at the rate of 1000 international units per hour. So that is calculated. The cardiologist will tell you, the books have given it. I'm not going too much into detail, but yes, you all should know that there is something called as continuous unfractionated heparin infusion. And just 6 hours prior to delivery, anticipated delivery, suppose she is 6-7 centimeters, you stop it and then you deliver her. Do not give it, if you give her epidural after that and then you deliver her, and 6 hours after vaginal delivery, you start it. And of course, keep your blood products ready. So these are the risk of thrombotic events. It is noted that unfractionated heparin has highest risk of thrombosis. Warfarin has the lowest risk of thrombosis, and second comes low molecular weight heparin. So warfarin is the best antithromboprophylactic, but you can't give warfarin in pregnancy in first trimester. Also, if you give in second, third trimester, there is a risk of intracranial hemorrhage because it crosses placenta, fetal intracranial hemorrhage. So you may give, but the best is low molecular weight heparin. If they can take it throughout the pregnancy, that is the best thing. So ours had a cesarean section because of breach, was in ICU, and I just want to say that in any woman, you should have risk stratification with MWHO, have maternal cardiac risk, obstetric risk, and fetal risk. So 3 things you should mention always. What is the risk with the with the medical disorder itself. Suppose it is epilepsy. What is the risk if with epilepsy? Sudden unexplained death in epilepsy for a woman. Obstetric risk with anti-epileptic drugs and fetal risk with anti-epileptic drugs. So like that for every medical disorder, if you think of the disorder risk because of the disease itself, because of pregnancy, and then of course fetal risk. Always you should divide it into 3 so that it is easier for you to answer in exam. Whenever there is applicable genetic consultation, suppose they are with congenital heart disease, you have to think about contraception, safety and efficacy. WHO has given a beautiful guideline. Please talk about WHO eligibility criteria when you are talking of contraception in any medical disorders. And if there is any cardiac medication to be modified, or for that matter, any medical disorder, this is a standard thing for any medical disorder. If there is any medication to be modified, suppose they are hypertensive, then do you want to modify ARBs? Yes, you should modify ARBs. You should change over. If there is any optimization of cardiac status to be done before pregnancy, such as suppose she has come with mitral valve area of 1.2, or if she has come with some cardiac event prior to pregnancy, then do you want to optimize it? Do you want to finish the mitral valve replacement, give her another 6 months, 1 year time, let her stabilize her disease, and then come to us? Yes, that is the best thing to have, isn't it? And then allow them to plan pregnancy. So the best is that you should have all friends in all departments, so that if there is a medical disorder and the woman is planning pregnancy, they should send the woman to you for pre-pregnancy counseling. These 2 guidelines are very, very beautiful. You cannot go for exam without reading these 2 guidelines. All the guidelines and whatever I have spoken and world over, these are the 2 guidelines that people talk about. And this is the way, these are the standard of care that we should be giving to all women in pregnancy. Even WHO guidelines are taken from these 2 guidelines. These 2 guidelines have obviously been taken from that ROPAC registry that I told you. Thank you all for my non-stop talking.
It was exceptional, Dr. Anisha.
Thank you.
Really
Thank
amazing.
you, Dr. Anisha. It was a fantastic talk. Really, you have covered each and every aspect of it. And as you have rightly said, no cardiovascular disease complicates 1% of pregnancy, and it causes 1/5 of the non-obstetric maternal death. Women should receive proper counseling on maternal and fetal risk prior to conceiving, as well as they should be thorough, always going on counseling and risk factors, always explained throughout the pregnancy. You have everything mentioned thoroughly in this thing. I am really very nice talk from Dr. Anisha. I congratulate you.
Thank you, ma'am.
And fantastic case presentation by Dr. Pallavi, and fantastic PD star by Dr. Sushma and Dr. Pragati. I really congratulate NOGS on this matter. Thank you very much for giving me this opportunity to be with you all. Thank you.
We'll have group photograph also now. And Pragati,
Yes. Should I stop sharing my screen? Wait 1 minute.
Stop. Yeah, we can.
Yes.
Okay. Wait, I'll open.
Urchir, please take a photograph.
Yeah. I have clicked one. Please all Bhakti was not there. Yes. Now this is going to be a picture of the day. Yes.
Thank you.
One more I will take. Just a minute.
Yes.
One more. Yeah.
Thank you.
Thank you so much. NOGS, Dr. Bhakti, Dr. Sushma, Dr. Kshama, Pallavi, Dr. Anjali, Dr. Pragati, and Dr. Avantika. So thank you so much. And Dr. Samta and all the others who have attended this. There was one question by Dr. Sushma that something I remember central venous cannulation. Yes. So whenever you are worried about overloading a patient, it is wise to do central venous cannulation. Then, you shouldn't be worried too much after that about overloading, underloading, all that. So it is a safe thing to do in labor. Yes, central venous cannulation is recommended. But nowadays with that intra-arterial catheters, and they give all the cardiac output and everything is there in those parameters, it is called as cardiac parameter. So cardiologists will have all that, or cardiac ICU will have all that. So we should take our patient to cardiac ICU and then deliver her there. So most of the things are available in that. Otherwise, it is easy to do central venous cannulation even for those people nowadays with ultrasound guided and all that they are doing. So it's quite not too much risky to do that. They do it ultrasound guided also. Tell your friends and cardiologists, nephrologists, I tell them that, you all have the patients. So when they are planning pregnancy, getting married, send to us. We will do pre-pregnancy counsel. We'll tell them how to plan their pregnancy, rather than they coming to us at 7 weeks with, whether to continue or whether to terminate pregnancy. Oh my God, that is such a difficult situation.
And one more question also I wanted to ask you, ma'am. Are you delivering these patients in ICU setups, or you are delivering them in your labor room? And how frequently do the cardiologists they attend the patient, if at all the patient is in labor room?
Yeah,
Because
a
time is
cardiologist will only
important.
come once. But it is
Once.
us, and because we don't have in-house cardiologists, but we have in-house critical care team, and we have the anesthesia and critical care, and we have a physician in-house. If there is low risk, like, mild MS, moderate MS, they'll deliver in labor room. But otherwise, yes, we prefer to deliver in them in ICU, because all the monitors, ventilator, all that is there in ICU, madam, for us. So we prefer to take them in ICU. It is just beside the OT. So all the
Exactly,
nursing
because,
staff and everything is very well geared to take care of all those things. In labor room, there are so many other things going on that you get deviated. So then we have one fellow of maternal fetal medicine who have with students with us. So we have one person constantly in the ICU with that woman, so that the care is not diluted for them. And then consultants, we are around always in the campus.
yes,
So
exactly, because the monitoring systems that you were talking about, the invasive arterial monitoring, that may also not be available in most labor rooms.
No, it is that is just a machine, madam. But the arterial cannulation they do through radial artery, and from there they connect the monitor. So that monitor is different. It is like that SpO2 thing monitor. It is a bigger one. We have only one. So cardiac monitor is there. But in multi-speciality hospitals, it is quite a common thing I've heard.
Okay.
But if there is a risk, like we had people with previous history of cardiac arrest and all that, we had, she was revived because of blood transfusion reaction, all that, we take them to multi-speciality hospital whom we have tie up with, and then we go there and deliver them there. So we have to jump up and down, because ours is like, we don't have 24/7 cardiologists. That's what I want to say.
Exactly, right. Okay, so thank you, ma'am.
I just wanted to ask one question, ma'am. Like, we have seen many patients of postpartum cardiomyopathy. Patients were all right, and then they had some PPH, or they had maybe they went into sepsis, and then they ended up into postpartum cardiomyopathy without knowing the cause, and they are always labeled as postpartum cardiomyopathy. So, wanted to have your opinion for that, or your word for that.
So postpartum cardiomyopathy is actually in next pregnancy. It depends on how well the heart has recovered from the insult. So most of the times postpartum cardiomyopathy, if their women are young and have no other comorbid conditions such as obesity, hypertension, diabetes, these are the three main conditions that I'm looking at. Then, and if the ejection fraction and all the parameters like that hypokinesia thing and whatever they had has come back to normal, more than 60% ejection fraction, then they do well in pregnancy. But if the ejection fraction is lesser than 30, then there is a risk that it will all recur again. So then it is advisable not to encourage them to have pregnancy. But if the cardiac, if the cardiac function has returned back to normal, they can have pregnancy. Very less likely to come back, with problems. Of course, you can say recurrence risk is always there. Almost 20% recurrence risk is there. But 80%, though, nothing will happen. But in pregnancy, when they come again, if there is anemia or uncontrolled hypothyroidism or hypertension like preeclampsia or anything that precipitates cardiac failure, we have to aggressively treat. Like for a normal preeclampsia, I may wait, BP of 180, 110, something like that. I will slowly bring it down and then, give her some time for steroids. For this woman who had postpartum cardiomyopathy, I will bring down the blood pressure and deliver her. We cannot go on like that. If there is any other comorbid condition, we have to treat it aggressively.
Just to diagnose a cardiomyopathy, we are just not even, it is in our imagination, and suddenly they are labeled as cardiomyopathy by physicians, and then we say, oh my God, we were dealing with this patient and a patient who was absolutely low risk patient. So that is something.
Yes, it can happen to
a low risk patient can go into
low
that.
risk patient. Yes. An obstetrician's prayer should continue for 6 weeks after delivery.
Yeah,
Yes,
it's the rule of 5, it goes on till 5 months and
5
everything.
months.
The rule of
Yes.
5 is always there.
True.
Yeah. Very nicely explained, Dr. Anisha. Very nice.
Yes. Thank you, ma'am. Thank you so
Congratulations.
much. Thank you so much.
Congratulations, Bhakti, for a fantastic webinar.
Yes. Pallavi,
Sushma
Dr. Bhakti. Yes.
and my Dr. Rajani and Dr. Pallavi,
Thank you,
Dr.
ma'am.
Jagati, and everyone. Really, thank you so much for a fantastic webinar.
Thank you so much. Thank you, everyone. All the best, Pallavi, and
Thank
your
you so much,
friends for your exam, final exam. You
Shall
should
we
pray
leave
that
now?
you get cardiac disease.
ma'am.
Then you
Shall
will
we leave?
hit a sixer and come. Yeah, what is there? Pray that you get cardiac disease.
Now they are so
Shall
well
we leave
prepared.
now?
Sorry?
Previously
Shall
they used to say, don't want cardiac disease, but now they will say कि cardiac disease का case आ जाए, because they are so well trained.
Yes, yes.
Yes. So taking the opportunity, I will, as a Secretary of NOGS, it's my duty to thank all of you who are present here. So before my official vote of thank, I just wanted to, place my condolence for a life which is lost today. A resident at Bhopal GMC itself is lost today. I think Dr. Rajni might be one resident has committed suicide. Whatever pressure she had, and she has committed suicide. So on this platform, I take opportunity. There's so many people who have logged in. Please don't break up to the situation. You can give up, you can leave, you can go on long leaves, you can appear for the exam again. Sab chhod sakte ho.
One
Zindagi
should
mat chhod.
talk here. Basic thing is one should interact. One should talk to each other.
People are connected to you. Don't leave this work. Leave whatever other things are there. So we really condemn death of Dr. Saraswati on GMC. She has
Very
committed
sad.
suicide.
Before that
Very
also,
sad.
Dr. K from KEM also has committed suicide.
That was in anesthesia. Yes, I heard that.
Yeah.
I did my undergrad, postgrad in KM. So
Yeah,
I felt
that
very
person
sad.
has also succumbed to this. I think residents should speak out, and they should interact with each other. They should not be introvert, rather.
So really heartbreaks and deep condolences for them. And if anyone is having this thought lingering in their mind, please give away that thought. Leave the studies, no worry. But you can come back and you can clear your life.
Everything can come back except life. That is true.
Yeah, very rightly said. Yeah.
So heal yourself. That is the thing which I wanted to say on this platform. There are so many residents who have logged in. Okay, so on my formal vote of thanks, today I'm thankful to our PG star, Dr. Pallavi Thakre. You have presented it so,
Thank you so much.
so good. You got so good remarks, which will be your credentials for your lifeline.
Thank you so much. Yes, sir.
Thank you so much. And really, the credit goes to our beloved Dr. Shama Kedar for training the students so well and taking so much interest and, correcting them, pushing them. I know her since so many years. She pushes.
Yes, ma'am. Yes, ma'am. Yes, definitely.
You have to present, and she helped them to make very good presentation, and she's a really good driving force behind them. Today's examiner, my own alma mater, my Dr. Anjali Kanare, thank you for accepting our invitation to be here as examiner. Dr. Avantika Gupta, thank you from AIMS for being with us and guiding our students. And today's, as the PG star was a PG teacher who has guided them so well. We all feel, हमारा दिल बोलने लग गया कि दिल अब कभी टूटेगा नहीं. चीज क्या है जान गए, दिल की बीमारी को कैसे ट्रीट करना ये भी हम सब जान गए. It's so easy. Thank you so much for being here. Today's chairperson, Dr. Shama Kedar, Dr. Manoj couldn't join. Was he there for some time? Dr. Bhakti?
He hasn't joined, I think.
No, ma'am, I think he couldn't join.
He was trying, he called me, but I couldn't see him. I don't know what has happened. I wish everything is fine at his. And today's MOC, Dr. Rajni Kamble, thank you so much. And last but not the least, our, persistently working team, that is Dr. Bhakti Gujar, Dr. Prachi Dikshit, and led by Dr. Anuja Bhalerao. They are making this PG Star program globally acclaimed and appreciated everywhere.
And let me confess here, Pragati. Actually, when Bhakti said your college has to present it, actually my shifting is going on from one labor room to another premises, and we are shifting in between that, whether to go ahead with this case presentation. We were in so much of dilemma, but we said yes, we will do it. And with my PG Pallavi and Rajni said we will do it, ma'am. We said okay, we go ahead. That was in my college. That's very good of it. Thank you very much.
So that is definition of Shama. कहीं भी करती रहती है, वही तो बात है क्षमा की. That is it. That is Shama. So you have done it so well. And last but not least, all the delegates who have joined in, thank you so much for taking the advantage and for making this program so successful. Our technical team, they keep on working, and our partner, educational partner, Corconnect, you are connecting with so many PGs, and this program will be a landmark in history of education. Thank you all.
Thank you so much.
Thank you all. Good night and have a great
Thank you
week
all.
ahead.
Bye-bye. Thank you all.
Thank you.
Thank you.
I should see
Thank you. Thank you, everyone.
Good night.
Good night.
Corona remedies RG, na?
Yes, Rujir
You are
Gandhi.
RG, na? मैं जानना चाहती
Rujir Gandhi.
हूँ.
I am Rujir Gandhi, madam. So I was quietly listening and helping wherever I
It is
could.
going on well. So ना link थोड़ा जल्दी दे दिया करो तो हम ज़्यादा पहले उसको
Yeah, ma'am.
या flyer
This
जल्दी
was,
so we can popularize it more on a broadly.
yeah,
Not
ma'am.
much.
We have got everything one day back only. On first only we got the photos. That's why the link was.
So with the names we can put up one flyer. Bhakti, let us declare the next PG activity so PGs can know.
I
She
think she
has
left.
left.
I think she left.
She has left.
So
Okay.
mostly next PG start will be on 17th of August. We'll let everyone know. The topic is under discussion.
And please send the link to me also. I can ask my PGs to join, because only when I am getting the link, like when I am involved, I am getting the link. So if you can popularize it more, it will be good.
I will do that, and I will keep
Sure.
in mind. But Dr. Anisha,
Thank you, doctor.
last
Good job, Pragati.
you have done wonderful job.
Thank
Really.
you. Thank you so much.
Bye-bye.
Okay. Thank you so much. Bye, everyone.
Bye.